what made you become a doctor, Dr. Lavelle?
Well, I don't know. That's a difficult question. There wasn't one specific thing, I suppose. I grew up in a small town in the Midwest in Wisconsin, and during the period in the late 40s, early 50s, when most of the doctors were general practitioners and every family had one, and I got to know a number of the general practitioners in our small town. Medicine seemed to fascinate me. My dad was a car dealer, not a physician, and there were no physicians in our family. In high school, I was fortunate enough to have an outstanding science teacher, and indeed most of the students in our high school class that took her course in chemistry and physics ended up in some type of scientific discipline, whether it be medicine, dentistry, biology, or chemistry, and I think she probably had the most significant effect as far as the scientific part of medicine, early scientific effect on my judgment as to go into medicine.
Where did you attend medical school?
Medical school I attended was at the University of California at Berkeley, at that time the early part, and San Francisco.
What year did you graduate in?
I graduated from medical school in 1967.
And what did you choose as your specialty?
Specialty that I chose was otolaryngology, or ear, nose, and throat.
What made you choose that as your specialty?
Again, that's a difficult question, because in medical school you probably change your mind many times as to what specialty you want to involve yourself in, depending on which class you just took or which professor just impressed you. It became pretty clear to me early on, probably in the third year in medicine, that I wanted to involve myself in some surgical discipline. Not that I didn't enjoy the other areas of medicine, particularly internal medicine, but I wanted to look for a specialty where I would primarily be involved surgically. Ear, nose, and throat, ophthalmology, urology, many of the surgical subspecialties appealed to me. My best friend in medical school was an oral surgeon prior to going to medical school, and he constantly counseled me as to the advantages of otolaryngology, and I found his advice to be quite good, and I just started down that road very early in medical school, taking electives and so forth, and enjoyed it, and I'm very happy that I made that decision.
So describe a typical day when you first started practicing.
Well, when I first started practicing, I finished my training at the Massachusetts Eye and Ear Infirmary in Boston, my residency training, and my initial years in medicine were in private practice, and later on I ended up becoming a full-time academic doctor, so that the life was somewhat different from the beginning till the end. But my first years in practice were 1974, and a fellow resident and I started a practice basically from scratch in the Boston area, which if we'd been wiser and older, we probably would have thought would have been crazy, because if there was any place in the world that didn't need 2 new doctors, it's Boston. However, we started in 1974. We had an office in Everett, Massachusetts, which is a suburb right next to Boston, near Chelsea, Revere, Malden, that general area. And we had an office downtown Boston. And within not too many years, we probably had the busiest practice in the city. Surgically, certainly the surgically most busy practice. A day in the beginning would primarily, I guess, start with surgery at 7:30, lasting usually the entire morning. depending on the number of cases or the length of the particular case. And the afternoons were spent in the office seeing patients. And surgical rounds were made in between surgical cases in the morning, and consultations and so forth in the hospital were done at that time. And then we would come home and be on call in the beginning very frequently, usually every other night for a number of years, till we expanded the call group.
When did you have office hours?
Our office hours were 4 afternoons a week. I don't remember now exactly, but Monday, Tuesday, Wednesday, and Thursday, I think from 1 to whenever they were done.
Would you care to describe more about your rounds in the hospital?
Well, the rounds were fairly traditional for a surgical practice. We basically would see the patients we had operated on in the immediate past, the day before, the 2 days before, depending on the type of surgery. I specifically was involved in a good deal of major head and neck cancer surgery, and many of those patients were in the hospital for a significant period of time. So I would make rounds on those patients either early in the morning prior to the surgical procedures, or if there were a number of surgical procedures with significant time in between, I would make rounds in between surgical cases. We did not have, or when I say we, my partner and I, did not have a large number of patients in the hospital for reasons other than post-operative care, or patients in those days, most patients came in the day before their surgical procedures, seeing them the day before their operation. It was unusual to have medical patients in the hospital. There would be some cases where patients would be admitted with very severe sinus infections, brain abscess from either ear infection or sinus, those types of serious problems, where there might not have been surgery involved, but nonetheless hospital care was required. But the number of those patients was relatively small.
And most of your patients came from around the Worcester area?
Well, no, as I mentioned, no. In Boston, which is the first 14, in the Boston and Boston area, the first 14 or 15 years of my practice, the two offices were quite different. The one office in Everett, most of the patients were from that general area: Everett, Revere, Chelsea, Malden, the North Shore of Boston. Our Boston office, the patients were from everywhere. There were many from the Boston area, but I think, at one time calculated over 20% of our patients were from outside the state. And indeed, we had a fair number of patients from outside the country, particularly the Middle East. I moved to Worcester in 1986, and some patients continue to come out to Worcester from the Boston area that I had either seen previously or had operated on or treated for serious or significant problems. But that was a fairly small percentage of the patients. Most of the patients were from the general Worcester area when I ended up out here. Some doctors in the Boston area continued to refer patients to me with specific unusual problems that they felt I had some particular expertise in handling. So in the beginning of my career, most of the patients were from Boston area, and at the latter part of my career, most of my patients were from this general area.
Did patients choose their physician?
Well, the patients I saw were primarily doctor referred. So they chose the doctor usually that sent them to me. There were a number of patients that came to me because of patient referral. I had treated a member of their family or something like that. And then our Everett office was much more of a community type of practice, and we saw patients that a larger percentage of patients, I would say, that are self-referral or other patients referred them in. But even there, I would guess maybe 50% of the patients were direct doctor referral.
Did you ever use the telephone to talk with patients?
Oh, sure. We used the telephone a lot. Usually at the end of the day, the messages were there to be followed up on, and we would call them, call the patients, or frequently, patients' mothers and dads who, usually the mother, of children that had ear problems and things of that nature. So the phone was a very important to the practice.
You never made any sort of house call, right?
Well, that's not true. It's very funny. My practice does not lend itself to house calls. We need a lot of different equipment and so forth to perform an ENT examination. And as I mentioned, the Boston office, patients came from all over the country, so it wasn't very practical to visit them in Ohio or somewhere. But in our Everett office, there were a handful of patients that I would stop on the way home, and it was more of a social call than it was a medical call. The number of times that a medical call was required because of some emergent problem was, I can't even remember, to tell you the truth. I can't remember one.
So what do you think it was like for your family to have a physician in the hospital?
Well, that's a hard question again. I think the family could answer that better than I could. I think medicine in general has been very good to me and to my family. It's been a great profession for me, and I've enjoyed it immensely, and it's been very rewarding professionally and every other way. And it allowed our family to enjoy a number of things that we would otherwise may not have enjoyed. So I think the family was probably very happy that I was a successful physician. Obviously, in the first several years, I wasn't home that much, but the children were very small at that time. And, excuse me, I was home, but I would get home late at night, and I was on call, as I mentioned, every other night, I think, for 3 or 4 years. Did not take a vacation for the first 3 or 4 or 5 years. But after that, we took vacations regularly. The kids were with us all the time, and we went to a lot of very interesting places with the children, and we had a great time. And so my guess would be, their overall judgment would be they're very happy that I was a doctor in Boston.
All right. So what were the most difficult illnesses that you saw in the early part of your career?
Well, the most challenging illnesses that occurred in my specialty, I'll limit myself to my specialty area because there were a lot of diseases floating around in the general medical world, yeah, many of which I have little expertise to discuss. The two major areas of problem in my specialty involved infectious disease, primarily ear problems and sinus problems. And when I say that, I don't mean to convey the idea of just general sinus complaints, but serious sinus problems with, as I mentioned earlier, potential complications of brain abscess, meningitis, that type of thing, which required very extensive antibiotic therapy and occasionally surgery, and which required the continued development of great antibiotics and to cover the various bacteria that cause these problems. Fortunately, the antibiotics have made an amazing difference in the practice of ENT, particularly in ear problems. Actually, prior to my career, most of the ear disease in the 30s, most of the ENT problems in the 30s and early were almost exclusively related to infectious disease, particularly ear disease, mastoiditis, which carried tremendous morbidity and mortality even. So that that was one area of major, and then of course the one that continues is cancer, which is my particular area of interest and expertise. And cancer was a huge problem when I started in medicine in ENT, and it's still a huge problem. And although there have been improvements, there's been improvement in treatment with adjunctive therapy and more specialized surgery, it still is a tremendous problem, as it was then.
So that's primarily what you saw early on in your career and your specialty, all of those that you just mentioned?
Well, in ear, nose, and throat, you see a lot of general complaints. I think I remember a study one time that cataloged the general complaints that people come to a doctor's office for, and I think 30 or 40% of them are ENT related. Doctor, my head is stuffy, my nose is stuffy, I feel dizzy, I have sinus problems, I can't hear well, my throat feels funny, I'm hoarse. All those complaints are still there, but all those don't represent serious disease. I tried to limit myself in your earlier question to things that were the most serious, and the two areas that I mentioned that were most serious are very aggressive infectious problems and cancer. But the other problems are still there, and they're still filling offices all over the country. People still have their ears plugged, they're blocked, their noses are blocked, they're hoarse, and so forth.
So those ear and sinus problems, are those the same that you've been seeing throughout your career, or have they changed at all?
No, they've changed somewhat. As I mentioned, antibiotics have drastically improved the seriousness of primarily the ear and even some of the sinus problems. There have been surgical techniques that have drastically improved the situation for youngsters with ear fluid, with the complaint of they can't hear early in school years, where fluid has been drained and tubes have been placed and so forth. So there have been a lot of improvements over the years, but there's still plenty of problems left.
What was one of the most important breakthroughs in disease treatment during the course of your practice?
Well, I think one of the most spectacular improvements in our field does not necessarily represent an active disease, but one that has got the imagination of not only the medical community, but the lay community, perhaps even more than the general medical community, has been the cochlear implantation, where basically artificial ears have been implanted in people who have been, prior to that, had zero chance of hearing, were totally deaf, but with the placement of these implants, they have had hearing restored. It's nothing short of miraculous, and that did not exist when I started in practice, and now is done routinely at primarily major medical centers. Here at the University of Massachusetts, we have an active program. So that has been a very dramatic breakthrough that did not exist at all at the time I did my training.
How about disease prevention?
Disease prevention has, I think, succeeded to a great degree in our specialty, particularly with smoking cessation and caution. Again, when I started in practice, people realized that smoking wasn't good for you. There were messages on cigarette packs and so forth, but the degree to which smoking can cause serious medical problems, and in my world, cancer of the head and neck, was not appreciated at the level it is now. And you rarely now see athletes running around spitting tobacco, and I can remember as a child, not a youngster, but a young person, seeing advertisements in books saying, I won't mention the brand of cigarettes, but I'm sure whoever, if anybody ever does watch this, who is my age or older, will remember the ads that this brand of cigarettes. More doctors prefer this cigarette than any other brand, and this was on Life magazine time, and though that has changed dramatically. I think that's probably the most significant lifestyle change that has influenced the diseases that we see in our specialty. Of course, in other specialties, there's been this change too in dietary changes for heart disease and exercise. There were no such things as exercise programs when I was in college or in medical school. Now there are healthcare clubs. If you throw a nickel out the window, you're liable to hit one.
So what is something that doctors take for granted now in terms of technology that you didn't have at some point in your career?
Well, something that I didn't have in my career, I suppose probably would be CAT scanning and MRIs that are now extraordinarily frequently utilized, and they're just taken for granted. If you go to the emergency room, the resident orders an MRI and a CAT scan the way we used to order a CBC. And it's been a tremendous adjunct to the ability of doctors to practice medicine successfully.
What technology is still being used that you used in medical school maybe or early in your career?
Well, most of the things that were there when we were medical students or early in our careers are still being utilized. Standard X-rays, the laboratory, cultures, blood counts, chemistry studies. The most important skills that are still critical are good physical diagnosis skills. So I can't think of much that was present when I was starting out in medicine that has become saw data that's not utilized anymore. I'm sure there are things, but they just don't pop in mind right now.
It's really the safety precautions that have changed, right?
The what?
Like the safety precautions and procedure changes. I mean, not so much as technology, but like, I guess drawing blood, like that's a whole different.
No, I don't think so. The technology has exploded during my medical career. As I mentioned, the radiology changes, the different studies that are available now, particularly now in the next generation. If you have somebody 20 years from now sitting in my chair, they're going to be talking about all the DNA, blood testing, and disease prevention and diagnosis. The safety situations that you're talking about that have to do with, I think you mentioned blood drawing and so on. Those really came in primarily as a result of the concern with HIV and to some degree hepatitis, and involved primarily trying to prevent transfer of the disease to the caregivers. Prior to the HIV epidemic, there wasn't that great a concern regarding that when blood was being drawn. My wife is a medical technologist. She drew blood on a zillion patients in California when I was in medical school in that area, and there were none of the precautions. And yet, I don't know of anybody either that she worked with or that I knew that contracted any medical problem from that.
Did you always have access to the new technology in your field?
Well, yes, I did. As I mentioned, I spent my early part of my career primarily operating at the Massachusetts Eye and Ear Infirmary, which is probably the finest ear, nose, and throat center in the world. And so we had access to pretty much anything that was new and useful very quickly.
Is there anything that you would like to see invented in your field or generally in medicine? A piece of technology or something else?
Well, the thing that I most look forward to and hope to see in my lifetime would be continued advancement in the treatment of cancer. and hopefully that one day more effective medical cures will be able to be advanced for malignant disease that don't require basically the devastation of radiation therapy or major surgical procedure or the poison of chemotherapy, where the medical treatment can be much more directed at the disease itself and pretty much limited to affecting the malignant tissue and offer the chance of real cures. Not all the time, nearly all the time. That does not exist yet for most malignant problems, and perhaps for any other than a handful of blood diseases and so forth. So I would like to see that come about, and I think it will. I just don't know when it will pop to the surface.
What were some of the most important drugs that you used early in your career?
Well, again, in my specialty, the drugs that we use that are of importance are primarily antibiotics, and there have been, I'll leave it to the internal medicine and infectious disease people to discuss this at more length, but there has been just a gradual development of new and stronger and better acting antibiotics to try and keep up with the new and stronger and more virulent bacteria that keep presenting themselves. So antibiotics are the primary area of medication that we're involved with. Occasionally we use steroids and things like that, but ear, nose, and throat is not a major user of the wide range of medical pharmaceutical products, cardiac drugs, high blood pressure drugs, those kind of things. So I wouldn't have much more to comment on than that.
Okay. And you always had access to the drugs you wanted to use?
Yes.
We'll move on to that. How did patients without money receive health care early in your practice?
Well, I think it depended on where they lived. Most of the patients who lived in major metropolitan areas that had no that had limited resources primarily received their care through the large hospitals and primarily in many of them, like the city hospitals, Boston City, San Francisco General, Bellevue in New York, Cook County in Chicago, and the other hospitals not as well known, but they had clinics and so forth that basically served the indigent. And some of these hospitals almost exclusively served indigent populations, like Boston City or San Francisco General. And so those were the areas where they received their care. In very small towns, for instance, the town I grew up in, it was primarily, I suppose, delivered, again, I was younger at the time, so I can't be an expert on this, but it was delivered basically as free care by the individual practitioner or the hospital emergency room.
How do you think Worcester is compared to other places over the years in terms of providing care for the underserved?
I can't give an answer on that. I'm not an expert on that. I know Worcester City was there for a long time. I know that we provided, here at the University of Massachusetts, provide a large amount of free care to indigent patients. I know when I was active in the clinic here, I would see a fair number of patients who had no resources. So as how they compare relative to other cities, I'm not an expert on that.
What were some fears and concerns about socialized medicine in the 60s, I guess, in the 50s, if you can go back that far?
Well, I can, believe it or not, go back to the, well, how far? I can go back to the early 60s. Socialized medicine was a concern in the medical community. There were people predicting there have been people predicting that socialized medicine is right around the corner since President Truman in I think it was 48, was one of the first to broach the general area of government medicine. As a matter of fact, I remember in college being involved in debates, and I would take usually the anti-side on socialized medicine and traveling around debating. But there were people who felt it was imminent. And that's 50 years ago. So, but it was primarily confined to the medical community. It wasn't a general, as I recall, it wasn't a general concern in the world at large. And that was a time when medicine was 90% private practice. Most of the private practitioners were individual practitioners. There were a much higher percentage of family general practitioners, as we called them at that time. And the American Medical Association was a very strong representative of that group. And so it was a major issue. And it has continued over the years to pop up from time to time. It became very, it came to the forefront during the Medicare debate, and there was a famous debate on television, even though they weren't in the same city, between John F. Kennedy when he launched his Medicare bill. I believe it was in New Orleans on national television, and had a big rally and balloons, and it was a national debate and a national announcement, and people watched it. It was on television. I recall, because I was in college, and it was spectacular. And Kennedy, as you're too young to remember, but Kennedy was a spectacular speaker and presented it very strongly. Now, this is before Medicare. This was the introduction of the Medicare bill. And I think it was several days later, the president of the American Medical Association was a fellow named Dr. Annis from Florida, who, in a very dramatic television event, the AMA rented the same hall that Kennedy had used for his, we have some interference here from the construction work, that Kennedy had used, but it was totally empty. And he presented the AMA's rebuttal. And actually the Medicare did not pass following that. But it brought the whole argument to the surface at that time. So I don't know whether I answered your question. I kind of rambled on. The interesting thing, Dr. Annis' son lived across the hall from me in college, and so we got kind of an insider's view of the whole national debate that was going on.
What were your feelings on Medicare and Medicaid when they came around?
Well, it was before I was in medicine, and I was more interested in that time studying hard, trying to get into medical school. So it was fairly, it wasn't something I was directly concerned with. I really didn't, the whole concept of Medicaid was not something that I even was very well versed in until I became a doctor. I mean, I knew it existed, but I didn't know the technicalities and the details and so forth. Medicare, I basically saw as I guess a lot through my parents' eyes and others, I kind of saw it as a something that was going to be very useful for the elderly population as healthcare changed, went from the individual general practitioner's doctor's office and the family into a much more of a organized kind of delivery of healthcare and the elderly, a good percentage of the elderly were going to need some help in making sure that they didn't spend most of their latter years worried about the devastation that any medical problem could occur to them financially. So to the degree I thought about it in depth, I considered it a good program.
How have your views on the programs evolved to the present day?
Well, I still think it's, that it's a valid, it served a very valid social role, and I think it's hard to think of the country now without Medicare. I think many of the people who would most strongly maybe opposed it at that time would be very strongly in favor of it now. I don't think the existence of Medicare is even the need for the existence of Medicare is even up for discussion. Like any huge government program, there are positive aspects to it and there are negative aspects to it. There have been great successes and there have been great problems. And I suppose, like most people, I think we ought to work very hard to try and maximize the positive parts of Medicare and try and work very hard to minimize the negative aspects of it. Medicaid is a much more complicated area, and much more politically sensitive. I don't think anybody would dismiss the idea that there are people who do not have the resources to provide for themselves, or perhaps even more importantly, politically and from a personal evaluation point of view for their children, small children, that they should have to go without good medical care because of that inability to pay. And Medicaid is basically the mechanism by which that is addressed. Again, does that mean that it always works well, that it's always administered properly, that there aren't huge problems with the way it's signed, and the way that providers sometimes are reimbursed? No, there are a lot of problems, and it's a work in progress. It has to constantly be monitored. Right now, there's a huge Medicaid crisis involved in inadequate reimbursement to involving adequate reimbursement to hospitals and healthcare providers. But again, it's hard to see a world where there isn't some program in place to try and help the very neediest among us because they need the help.
How do you feel that the government's overall involvement in healthcare has affected physicians specifically?
Well, the government's involvement in healthcare has mirrored the increase in the importance healthcare has to the American economy. The percentage of gross national product involved in healthcare has gone like this. Correspondingly, the government's involvement has gone like this. It's just too important for the government to just stand by the roadside and say, well, whatever happens is going to happen. And so the government plays a huge, many might say dominant role in the world of healthcare, starting with Medicare, which I don't know what it is now, but what percentage of the healthcare dollar, but it's a very substantial one. If you add to that Medicaid, it becomes even more substantial. And then, of course, all the regulations and so forth that flow from government involvement have dramatically changed the position of government now. And the laws that have been passed in addition to that, for instance, the laws that encourage HMO production, which basically changed the map of medical care provision in the non-pure governmental sector. That was occasioned to a good degree by federal legislation. So I don't think there's any way to answer the question of what importance is government in healthcare is to say it's a dominant position.
But how have you and other physicians been affected by government's involvement?
Well, the fact that we as physicians live in the healthcare world, that's how we make our living, that's what our profession is about, that's the work we do. To the degree that the government increasingly is calling the shots in that world, it directly impacts us. Not always negatively. I mean, some of the things that have, many of the things that have come about because of government involvement have been very positive. As we talked about Medicare. And so everything that the government does in healthcare isn't a negative. When the negatives occur, they're very frustrating because it can be very difficult sometimes to get a response or to change what one sees as unnecessary intrusion or unsatisfactory directive or something of that nature. So there are positives and minuses, but to not accept the fact that it's there and it's going to continue is, is unrealistic.
And what do you think the effect's been on the public's access to care in general?
What do I think?
How do you think the government has affected the public's access to health care?
Well, I think if you just look at the two major government programs, Medicare and Medicaid, it has positively affected the government's access, the individual's access to health care.
Okay. When did HMOs first impact your practice?
Well, I suppose depending on what part of the country you live in, that question can be answered almost in different decades. I think HMOs made a significant, began to make a significant impact in healthcare practices in Massachusetts, beginning primarily, I would say, in the late '80s, and then evolved in the '90s to becoming the major factor in the private sector.
And what was their impact on your practice?
Well, my practice, or the practice of otolaryngology here at the University of Massachusetts, or the doctors who work in my department, or doctors in general, the HMOs or the managed care, however you want to. It's just a different. It's a different structure. Some require pre-authorization before they can see a before an individual can see a specialist. So now, if a patient has an ear problem or a throat problem or a nose problem, in many situations, they can't just go to an ear, nose, and throat doctor. They have to go to their primary care doctor and see them first or talk to them. And if the doctor thinks it's significant, that doctor will refer them on, or so they have to authorize their visit more frequently than in the past. There's a lot more paperwork. There are a lot more approvals. There are a lot more, and there are a lot more checks and balances. That if you see somebody and you think they need some specific therapy or surgery, in many situations that has to be authorized, and there are very many ways where that can be done depending on the different managed care company. So it's made it much more complicated. It's no longer just the patient and the doctor in the room making the decision as to what that should have to be done.
All right. Well, what would you like to see ultimately happen with the government and healthcare? You really haven't done a view of your.
Well, that's a Pollyannish answer. I mean, the fact that the government is involved in healthcare is a given. That's not going to change. And I suppose that I would say that I would hope that their involvement is, handled with the greatest degree of expertise and goodwill and care about making certain that they get value for the tax dollars that go in, that the money is spent appropriately, and that things that are required for the American public to provide for their health care are supported, and that there are intrusions into the healthcare world that are less desirable and interfere with the quality practice of medicine are minimized, and people work very hard to eliminate them, and that a balance is continued to make certain that care is exercised to make certain that in an attempt to purely control expenditures, that attempts are made to make sure that in doing that, that life-saving or life-serving procedures and so on are not lost. So I think that's all we can hope for. It's going to be an organic process. It's going to be a give and take and a push and a pull to try and maintain quality. And every effort should be exercised to be on the positive side of that. And that will mean there will be situations where we don't always, I mean physicians don't always agree with all the decisions that are made, but I think we should make an effort to work with the people in government to try and make certain those decisions are the right ones as much as we can. If we're always seen as opposing everything, then it is quite likely that we won't be asked that much, that frequently to be involved in the decisions.
Yeah, going there for long for the government now. How much did it cost for you to go to medical school?
It didn't cost me very much. I was, as I mentioned, I went to the University of California, and I was fortunate to be able to go there because it's a state school and I was not a state resident. And unlike here in Massachusetts, by law, all students in the medical school have to be state residents. In California, that was true 90%, but they allowed 10% of the class to come from out of state. In fact, as I mentioned, my best friend, the oral surgeon, was from Illinois. And I was also very fortunate. I received a scholarship when I went there. Having said that, I think the tuition, my first year, I don't think there was a in-state tuition. There were fees for equipment and so forth. And I think the tuition during the time I was there increased to a couple $1,000s a year at most. I can't remember the exact amount, but it was negligible between the scholarship and the amount of tuition that they charged. It was very small.
Did you ever feel that the costs of medical school back then influenced any doctors or any students in the choices they made after graduation in terms of how they chose to practice?
At the time I went to medical school, not really. I think that there were some members of the medical school class who chose specialties with the idea in mind that they were they offered more generous financial remuneration than others, but this was way before the days when people had major loans and things of that nature. So I don't think, I could be wrong that in maybe one or two cases, but I don't think anybody chose their specialty because of any debts they had accrued or something of that nature.
How do you think school costs today influence the choices of our doctors?
Well, the school costs now, again, we're at a state university here, and the tuition fees at the university here are substantially smaller than the private medical schools. So I think our students are very fortunate that they don't generate the kind of tuition bills that they would if they were attending one of the private schools in the area. But I know that in some of those situations, the amount of debt that these youngsters acquire is unbelievably large. The kind of debt that in my day would be the amount of money you'd be paying on a home mortgage. These kids now leave school with that as a loan that they have to pay, and that's on top of loans that they have rung up in undergraduate school, because people forget, but undergraduate school now is not that cheap. And if you're going to a private school with an undergraduate school that's charging $30,000 or $35,000 a year in tuition, and then you go to a medical school that's charging $35,000 or $40,000 a year in tuition. You can see why that can end up being a substantial debt for a young person, man or woman, coming out.
How have you seen medical school evolve in general? I mean, overall, like the education, being very much involved yourself in medical school?
Well, I think that the biggest change I've seen in medical school training I'm not an expert on this, even though I'm a medical school professor. I'm not involved in the operationally of medical school policies in providing education to the students on a daily or weekly basis, and I'm not on any of the policy committees or things of that nature. But the biggest change, I think, has been an emphasis on that was pushed into the system involving primary care and family practice that coincided somewhat with the managed care and so forth. So that now that you see many medical schools, this one is considered one of the top in the country as far as its primary care commitment and productivity. You see medical schools with a much more of an outlook in that direction. When I went to medical school, it was totally specially directed. That there was no thought given to basically to managed care, or not managed care, but primary care, family practice. Everybody who finished medical school was going on to some specialty. The idea of going into family practice or general practice did not exist, and basically if you did that, you were basically, people wondered whether you were thinking very clearly. So that I think is probably the biggest sea change in medical education. Things that surrounded that whole psychological change in the medical schools in the country.
How have doctors' salaries changed over the course of your practice?
Well, I'm not the best person to ask. The first half of my career I spent in private practice, and the second half I spent in university practice. I think in the world I live in the surgical specialties and in general, that there have been, as there has been in all areas of medicine, there's been significant pressure, downward pressure on doctor reimbursement and physicians' general salaries being placed under pressure. Having said that, my sense is that most of the physicians in the areas that I'm most conversant with are still receive very good salaries and are rewarded appropriately, rewarded well for their work.
How has malpractice insurance changed over the years, as well as its impact on doctors?
Well, malpractice insurance that's an easy question. That just, over the years, it just gets more expensive. And depending, when I say there's been substantial pressure on doctors' salaries and doctors' reimbursements and so forth, there has also been a more significant increase in the expenses involved in medical practice. So, there are a lot of reasons you see fewer and fewer doctors' offices in operation, and one of the reasons is that financially they're more and more difficult to make them a going operation unless you get larger groups together. And one of the major contributors to the increased expenses has been the just seemingly relentless increase in malpractice insurance. cost.
How did you learn the business of medicine?
Well, you don't have much of a choice. At the time I went into practice, still most people went into practice. Nowadays, most people get a job, and there's a big difference. Getting a job means you negotiate, you get a salary, and you get benefits, and you go to work, and you're basically you're an employee. When I finished, the majority of doctors still went into practice. You went out and hung up your shingle, put your name in the yellow pages, and waited for people to come. Well, when you did that, it was you basically were starting a small business, and you had to learn the rudiments of a business, small business practice. It's not that complicated, to be frank. I mean, you provide a service, you get paid for what you do, you try and make certain that you are paid for what you do, and you hire people to do the tasks that are required in your office, and you buy supplies and pay for the telephone and the rest, and you meet with your accountant at the end of the month, and you look and see what the expenses are and what the outlay. So it's basically business 101, but that has become much more complicated as the time has gone on because of all the paperwork and all the requirements of all the third-party payers changing dramatically, the increase in managed care, and the relentless increase in expense. So you basically learn the business on the job.
What are some changes that you've seen in Worcester in terms of the demographics of the community?
I can't answer that question. I'm not close enough to know that.
Why exactly did you choose to practice here in Worcester?
Well, I came to Worcester because this is where the medical school was that offered me the job that was very attractive at the time. As I mentioned, I'd been in private practice in Boston for close to 15 years. It's very unusual to go from private practice to an academic position. If anything, it's more frequent the reverse because it's, but my private practice situation in Boston was quite unusual. I was involved primarily at the Massachusetts Eye and Ear Infirmary, and worked every day with residents and taught residents. Had been successful there. Was, among other things, president of the medical staff and on the board of trustees, and I became a very active participant at the Mass Eye and Ear Infirmary, and was involved in doing some medical research, and I was doing some basic science research out at the Bedford VA on olfactory neuroanatomy, and basically had kind of a academic orientation of my practice on the side, even though it was private practice. And then this job opportunity presented itself, and I came out here and discussed it with Dr. Wheeler, who was chairman of surgery at the time, and it looked like a tremendous opportunity and something I would very much enjoy. And I decided to come, and I'm very happy I did. And that's how I ended up in Worcester. But
would you like to talk more about how the university practice compares with the private practice, or maybe how practicing here in Worcester compared to practicing in Boston, the small city, large city?
well, I haven't practiced for the last several years because of a medical situation, but I did practice for 5 or 6 years in Worcester, here at the medical school. And my primary practice here was involved with head and neck cancer surgery. Although I did do other things as well, general ENT situations. We do not have a very, a huge department, so we had to take care of the other things as well. It's kind of a funny situation in that my practice in Boston was actually probably much more specialized given the referral base. As I mentioned, almost 20% of our patients were from outside the state. Nearly all the patients in the Boston office were referred by other doctors, a good percentage of them ear, nose, and throat doctors. So they very frequently had very highly specific kind of problems requiring very specialized approach. Whereas in Worcester, at the medical school, the number of patients I saw with that degree of specificity of their problem was less. And although I did see a large number of patients that had very serious cancer problems, I also saw a large number of patients who had general laryngology problems. The practice of medicine is the same wherever you go. Once you close the door, put your head mirror on, go to work. Taking care of people is the same whether you're in private practice or in university practice. So as far as the practice of medicine, you just do the best you can. You bring the best you can to the office every day, and that's the best you can do. And that's what you do whether you're in Boston or whether you're in Worcester.
All right, well, I just have a couple of questions left. With medicine being such a changing field, how have you found yourself keeping up with the changes in terms of education since you graduated from medical school and up till now?
Well, I've been very fortunate. I think it's a good deal more difficult if you leave the area that you received your medical training in and you end up out far in the periphery, because you have to basically get in the plane or the car or somewhere and go to meetings and keep up that way. I never basically left. I spent the first 15 years basically at Harvard Teaching Hospital, actively involved. One of the busiest surgeons at that hospital, involved with medical students and residents on a daily basis there. And medical students and residents keep you very much involved as far as what the newest and most appropriate therapies are for different problems. From the day I finished my residency. So there never was a time when I was away from the academic center. And then when I left there, I came here, which is to a medical school. So it's pretty much the same. I mean, if people say, how are you going to keep up with medicine? Well, you have to regularly go to a medical school or to meetings. Well, we're already here. We're at a medical school. So I've been very fortunate. There's never been a period when I was separated from being attached to the most recent, the most up-to-date in my profession.
Right. We're actually